Ya, dipersilakan dokter. Ya, apabila sudah siap, maka kami akan masukkan 3 peserta tersebut, dokter. Waktu dan tempat kami serahkan kepada Dokter Bobi. Terima kasih, dokter.
Ya. Good morning, everybody. Welcome to PERDAMI annual meeting. In this morning, we can see the online presentation competition, yeah. And in this morning, there are 3 presentation, yeah. And I'm Dr. Bobi Ramsar Gunastepu as a moderator and judge, and Dr. Siska Widiawati as a judges too. Okay, for the first opportunity, we can call Dr. Diah Purwita Triangga Dewi, IGS FP 06. Okay, the time is yours.
Assalamualaikum warahmatullahi wabarakatuh. Selamat pagi. Apakah suara saya cukup terdengar?
Ya.
Baik, terima kasih atas kesempatannya. Ini nama saya Diah Purwita Triangga Dewi. Pada pagi hari ini akan melangsungkan presentasi dan tanya jawab mengenai free paper saya dengan judul efektivitas selective laser trabeculoplasty sebagai modalitas pada pasien-pasien glaukoma.
Mohon izin, video langsung kami play ya, dok. Setelah itu dilanjutkan sesi tanya jawab.
Assalamualaikum warahmatullahi wabarakatuh. My name is Triangga Dewi. In this moment, allow me to deliver my presentation about selective laser trabeculoplasty as a valuable modality of treatment in open-angle glaucoma patient. As we all know, glaucoma is a progressive disease that impacts the quality of life. It is estimated that by the year 2040, there will be 57.5 million people in the world living with open-angle glaucoma. In Asia, prevalence POH is still higher. And in recent years, selective laser trabeculoplasty gonna be option for lowering IOP. So this procedure introduced by Latina and Park in 1995. SLT works by using laser to increase the outflow of aqueous humor through the trabecular meshwork, especially in the pigmented site. The largest spot size in SLT prevent collateral thermal damage, and we can see here to the trabecular meshwork tissues after laser in ALT giving a scar. Meanwhile, in SLT is very minimal. This laser promotes faster healing, has a relatively safe profile, and demonstrates cost effectiveness. Notice the newest algorithm for European Glaucoma Society shows that SLT is the first-line therapy for POAG. When we meet POAG patients, we have a choice whether to give drug first or laser first. Therefore, in this study, we want to evaluate IOP lowering effect of SLT and correlate its parameter to the successful rate in open-angle glaucoma. This study is a prospective conducted November until December 2022, located in glaucoma outpatient in National Eye Center Cicendo Eye Hospital, and used consecutive sampling. So this is the criteria in the study. We did SLT to the all AG, either primary or secondary, and subsequently patients or never had glaucoma therapy, or patient that under therapy but IOP still high. And this is the exclusion criteria where we vary glaucoma, history of glaucoma, and loss of light. In this study, we set the laser power starting on 0.6 millijoule with area was 4 quadrants. Before SLT, we recorded some data as IOP pre-laser, visual acuity, OCD, and hybrid test. We measured IOP post-laser 1 week, a month, and 2 months of follow-up, and we recorded the same parameters at the end of follow-up with successful criteria determined as greater than 20% IOP reduction. The statistical method used in the study was pair t-test and Spearman's right correlation test. So this is the result. There were 19 eyes or a sample, but 2 eyes were excluded due to the subject didn't come to hospital. Here's from the table, we got the most diagnosis, POHE, about 65%, amount of medication, mostly 1 until 2 types, about 41%, with uncontrolled IOP as indication of the most indication of the laser. We got baseline IOP 21.12 plus or minus 4 millimeter mercury, and total laser energy SLT we got the mean 75.6 plus or minus 16.8 millijoule. And visual acuity, CDR, RNFL, V, and MD result are not much different. Compared to another study in Thailand population, there was similar demographic data. And although we had a limited sample in our study, the result provides similarities to the other studies. Then turn to the result of post-IOP measurement. We got decreasing of IOP and the end of follow-up baseline IOP 16, and percentage of IOP reduction was pretty good, reaching 26.25%. And at the month follow-up, and still compared to the same study, the IOP reduction successfully reached more than 60% until 2 years follow-up. We analyzed the successful rate in the study, increased every follow-up, and reached 76.5% at the end of follow-up. There was similar result as we can see. Ansari et al. Research SLT at 10 years follow-up resulted in 72% successful. Also from Gork et al. Study stated that SLT gave success in 75% eyes. Once again, although we had limited sample, the end result is equally successful. This table showed about correlation about total laser energy with various measurements in open-angle glaucoma and gives significant result at month's IOP reduction. And this figure shows the distribution of the success of reduction at the month compared to another study. Realinis stated that no significant relationship between laser energy as a predictor of success of the procedure. Ultimately, we conclude SLT effectively reduced intraocular pressure by more 20% and gave satisfactory result in OAG cases, either as initial or adjunctive therapy. And noteworthy, SLT can help patients to reduce dependency on anti-glaucoma medication. Limitation in this study was sample data was too small and need longer duration of observation, so further studies are needed. I'm very grateful to my consultant who has provided input that and a lot of help. Thank you. Wassalamualaikum warahmatullahi wabarakatuh.
Okay, thank you, Dr. Dia, for the presentation. Now we open discussion. Maybe I want to ask, Dr. Dia, can you say on your study that the SLT is superior than the anti-glaucoma medication for the reduced IOP?
Okay, thank you, Doctor. Maybe SLT could be an alternative treatment, especially in early condition of glaucoma. Over decades, we've been using drops or medication for treating glaucoma, but still there was so much challenging, such as compliance of the patients, and sometimes the patients can get a dry eye or ocular surface disease as the side effects. And with this laser, we can delay or eliminate these side effects. And this laser also could address compliance, also decrease fluctuations, and will help less toxicity for the ocular surface. So interestingly, also the SLT could be used as a primary therapy, as adjacent or adjunctive therapy, and also as a replacement therapy. So it gives much more benefits than anti-glaucoma medication. Thank you, Doctor.
Can we use the SLT is the prophylaxis management for the ocular hypertension or the family history with glaucoma?
Yeah. Okay. Thank you, Doctor, for the question. SLT is also recommend to do in ocular hypertension patients. Some RCT trial from Garg et al. Said the SLT gives a good result, and 75% subjects will result in drop-free or no medicine at all after giving SLT laser. So it's recommended to do in ocular hypertension condition.
Thank you, Dr. Dia. Okay, for the next presentation, we call Eric Chung with INAPOS FPGR15. Please, Eric Chung, the time is yours.
Good morning, judges. My name is Eric. Here I'll be presenting on my systematic review for deep learning to evaluate pediatric cataract. IT team, could you play the video? Greetings, panelists and guests of PERDAMI 48. My name is Eric, and I'll be presenting to you original research titled AI for Little Eyes, a systematic review of deep learning in evaluating pediatric cataract. Here are my outline. WHO has deemed congenital cataract as a leading cause of childhood blindness. However, detecting CC at early stage is challenging because progression is often asymptomatic and access to specialized ophthalmic care could be limited in certain regions. Convoluted neural network, or CNN, is a powerful tool for medical image analysis and classification. In ophthalmology itself, it has been used for several diseases detection. Systematic search was performed from February to March in 4 different databases and 1 other source. Search terms and limiters are as follows. Papers included in the study focus on DL algorithms in diagnosing and predicting CC. They must also include the details on DL algorithms, as well as evaluation metrics such as specificity, sensitivity, accuracy, as well as area under the curve. Exclusion criteria include review articles, conference abstracts, and editorials. Data extraction form was first created based on minima and were performed by 2 assessors independently. Extracted information are as follows. We then perform risk of bias assessment using Quadrats 2 tool for diagnostic studies and Consort AI for RCT. Such results yielded 100 records and 5 were included in the studies. All studies were performed in China. 4 were retrospective studies and 1 RCT. They all have different objectives, including detecting, grading, and predicting CC. Furthermore, on CNN, these studies had different CNN architectures. They also had differing amount of training data sets. Internal validation were mostly performed using cross-validation. External validation data sets were collected from clinical settings as well as websites. Reference standard was based on panel of 2 to 3 ophthalmologists. Papers were then assessed for risk of bias with following results. On algorithm performance, CNN had really high performance on identifying CC on all diagnostic parameters. Highest performer was CNN on Long et al. When compared to human, they were contradictory results. Long et al. Reported better performance on CNN as compared to human, while Lin reported otherwise. Algorithm performance on grading for area, density, and location for CC was high on all diagnostic parameters, with highest performance on Long et al. CNN for diagnosing and predicting CC demonstrated reasonably high diagnostic value. This is due to its features such as hierarchical feature, non-linear mapping, as well as transfer learning. Although in certain cases, CNN seem to perform better than humans in diagnosing and or grading CC, there were several methodological flaws in the studies. These include heterogeneous measured outcomes, compromised generalizability of algorithms, greater bias due to few reference standards, overfitting due to small training data, sample size calculation were not performed, poor quality images were also not admitted, and as well as one study did not do external validation. This study is not without its limitations. Datasets were homogeneous as it was collected in one country. Heterogeneities due to differences in imaging modes and internal features of DL models were also seen. Accuracy measurements were unavailable for some studies or sub-datasets, and some studies lack of external validation or comparison with other professions. In conclusion, DL algorithms exhibit superior performance in diagnosing and predicting CC, and it also shows potential in limited resource settings to improve diagnosis. However, further research is needed to integrate DL algorithms in daily practice. Here are my references. Thank you.
Okay, thank you, Dr. Eric, for the presentation. Okay, now we open discussion. Dr. Siska, I have a question for the Dr. Eric, please.
Okay, thank you, Dr. Bobby. Dr. Eric, this is a very interesting study. So all the study conducted in China, yeah?
Yeah,
That is amazing, yeah. But the result was high accuracy and validity in deep learning algorithm in diagnosis congenital cataract. But still you mentioning about it is not as accurate with human diagnosis. How does it show? Because if it is lower than human diagnosis, then we can use it as AI in the future. What do you think about it?
I'm sorry, could you repeat the question? Sound was quite blurred.
Okay, you despite the accuracy in the validity of the deep learning algorithm in your study found, you also said that it is still lower compared with human diagnosis.
Yeah.
Yeah. How is it so? Because if it is lower, then we cannot use it. As you mentioned that we can use it in the remote area and etc.
Okay, so according to the studies that I've read, the results were contradictory. So one paper said it was better in deep learning, the other said it was worse in deep learning. Why it could be lower? It could be because of the training data sets that has been collected. Because one, congenital cataract is a very rare disease, so the training data set is not as big. That's why the train algorithm couldn't be as good. So let's say if we gathered more data, it could perform better. However, I think it's not going to be in a short-term period. Though it could be a good tool to help the ophthalmologists in the remote areas to gain certain early screening.
Okay, thank you. So we need to confirm then, yeah? We need to confirm after the deep learning, and we still need to confirm with a human diagnosis.
For now, yes.
Okay, thank you.
Thank you, Dr. Siska, for the question. Okay, the time is up. We go to the third presentation. Dr. Teresia Dwi Amelia with the coding INAS HOPS FPGR3033. Dr. Teresia, the time is yours.
Okay, thank you, Dr. Bobby. Today I would like to present my paper, The Expression of Alpha Smooth Muscle Actin in Contracted Socket. IT team, could you play my video, please? Thank you.
Thank you for the opportunity. Today, I would like to present my paper, The Expression of Alpha Smooth Muscle Actin in Contracted Socket. The goal of ocular evisceration surgery is to create a well-fit ocular prosthesis with a deep fornix and appropriate conjunctival covering that resembles the eye as naturally as possible. An ill-fitting prosthesis can also result in poor cosmesis, physiological trauma to patient, additional injury and infection, in addition to these other undesirable outcomes. Socket contracture is a common complication following socket surgery. The shortened orbital tissue brought on by fibrosis is what the result of contracted socket. The shortness of conjunctival lining with shallow or absent fornix can happen under a variety of circumstances, such as previous radiation, immunologic condition, orbital implant exertion, or after thermal or chemical trauma. Management of acquired anophthalmic socket contracture mainly involve replacement of the cicatricial conjunctival tissue with a healthy graft to reestablish a deep fornix that allows a proper subsequent fitting of an ocular prosthesis. Since then, myofibroblast has been discovered in almost every fibrotic disease characterized by tissue remodeling and retraction. And alpha smooth muscle actin, or alpha SMA, is a specific marker of myofibroblast. A certain amount of fibroblast contraction is required for wound healing, but too much might result in the growth of scar tissue. It has been hypothesized that fibroblasts upregulate alpha SMA expression during this time of severe contraction. And the objective of the study was to identify the expression of alpha SMA protein in myofibroblasts produced by ocular socket contracture. This consecutive study observed 5 patients with severely contracted socket, and the patient had to meet the following criteria to be included according to Taufik criteria, and underwent fornicoplasty and buccal graft surgery. Patient come to our hospital between October 2022 and February 2023. And patient were operated under general anesthesia and carried out by 3 ophthalmologists from reconstructive and oculoplastic subdivision. And the fibrotic tissue was taken from the lower conjunctival fornix area of the contracted socket, served as a study sample. For micrometer section of conjunctival samples were prepared, immunohistochemical staining was performed using a primary clone anti-human monoclonal alpha SMA antibody. And we provide data on Excel spreadsheet, statistical analysis conducted with the SPSS, and considered as a statistically significant with p-value less than 0.05. Table 1 shows the demographic data and preoperative characteristic of the patient. The mean age was 48.8 plus minus 13.84, and 4 patients are men and 1 is a woman. We found that the ocular trauma was the main cause of the anophthalmia. For the number of prior surgery, patient ranged from 0 to 1 with signs of recurrence. 1 patient with grade 3 contracted socket, for 2 patients with grade 4 and 2 patients with grade 5 based on Taufik classification. And the duration of anophthalmia ranged from 33 to 66 years with a mean of 39.6 plus minus 15.61. And 3 patients used the prosthesis every day during the day, but 2 patients never used the prosthesis. In the study, there were 2 out of 5 or 40% positive alpha SMA expression with history of recurrent contraction, and 2 or 40% negative expression with no history of recurrent contraction, and 1 result that could not be assessed due to the limited number of samples containing fibroblasts. Linear regression was done to analyze the correlation between some variables and the expression of alpha SMA. The correlation between age of expression of alpha SMA was not significant, followed by recurrence of contracted socket, grade of contracted socket, history of prosthesis use, and also duration of anophthalmia. And we found that these variables were not significant with correlation of expression of alpha SMA. Socket contracture may result from a variety of factors, including fibrosis occurring due to these several reasons. The presence of Myofibroblasts, which are the cause of socket contraction, is supported by the observation of alpha SMA expression in patients with history of recurrently contracted socket. With this expression of alpha SMA, it's emphasized that in the future, antimetabolite injection can be given to the patient's socket area as a prophylactic therapy for recurrent contracted socket due to fibrosis prevention. Of course, further research is required, ideally with bigger sample size. And this is the conclusion of the study. Alpha SMA levels can be detected in patients with contracted socket. Recurrent contracted socket are more likely to display positive alpha SMA, but the correlation is still insignificant because of small sample. This may allow for need for the administration of antimetabolites in the patient with recurrent contracted socket to avoid the recurrence of fibrosis. Thank you.
Okay, thank you, Dr. Teresia. Okay, one question I ask for you. From your study, you have 2 patients with positive alpha SMA. This patient have underlying disease like autoimmune or something else?
There was no underlying disease from this patient, but this patient has recurrent contracted socket. This patient has more than one reconstructive surgery for the contracted socket, doctor.
So you notice the antimetabolite is very useful for this case, yeah? So
yes, doctor.
Okay, is the antimetabolite is necessary to the SOP for the evisceration to the socket?
Okay, thank you for the thank you for the question, doctor. In this time, we do not use in our hospital do not use antimetabolites to given to patient after the evisceration or enucleation surgery because it's haven't established that the given of antimetabolites it's necessary or not. So this study is a previous earlier study to we have to find if patient with alpha SMA is quite higher in contracted socket. So we try to make another study to compare the patient with antimetabolites and given with steroids injections after evisceration or enucleation, doctor. So we need another study to do for using antimetabolites for patient with contracted socket, doctor. Further study.
Thank you, Dr. Siska. Have question for?
Yes, time is up, Dr. Bobby. But I think I agree that I think we need a further study for this before you suggest to give or recommend antimetabolite because it's only small sample and you only find 2 out of 5 patients with alpha SMA and we still think about more bias and everything. Thank you.
Thank you for advices, doctor.
Okay, thank you, Dr. Siska. Okay, all the presentation have presented this morning. So we close this session and we close and we have to see in the annual meeting offline in Jogja. Okay, see you.
Thank you, judges.
Bisa leave kita?
Thank you for Dr. Bobby and Dr. Siska.
Ya, boleh live ya.
See you again at PIT, dokter. Oh ya, untuk Dr. Bobby dan Dr. Siska, izin reminder dokter untuk sesi dokter selanjutnya sudah kami kirimkan melalui PM juga ya dok, buka kembali untuk jadwal dokter. Terima kasih dokter.
Terima kasih. Ya,
Yang selanjutnya sesuai dengan jadwal kan ya?
Iya betul dokter.
Terima kasih.
Terima kasih dokter.
Oke, yuk izin live.
Terima kasih, Dok.
Terima kasih, Dok.
Pada peserta, dipersilakan untuk meninggalkan ruangan ya dok. Terima kasih semuanya.
Terima kasih.
Online for PIT PERDAMI. Today we have first of all, thank you to the judges, Dr. Fitratu, also to the contestant and the committee that already that facilitated our meeting this day. Today we have actually we have 6 contestants, but only 4. Yeah, only 4 already joined with us. The first is Dr. Abdi, and then Dr. Rofa, Dr. Azara, and Dr. Christy. I think I will proceed to the presentation of Dr. Abdi, I think, yeah. Dr. Abdi, are you ready?
Yes, doctor. I'm ready, doctor.
Yeah, okay. You're already in the room, so I will ask the committee to play the video recorded. Yes, please, Dr. Abdi.
Good morning, doctor. My name is Abdi Sasragunanegara. I would like to present my research correlation between platelet parameters and the severity of primary open-angle glaucoma. As introduction, 4.5 million POAG patients were bilaterally blind in 2010, while increasing to 5.9 million people in 2020 worldwide. Currently, some evidence has indicated a role for pro-inflammatory factor. Watanabe et al. Have observed improvement of platelet coagulation and inflammation in the endothelium of slime canal in POAG. Several studies reported that platelet parameters increase in patients with neovascular glaucoma and PAGG. PDW and MPV were significantly increased in patients with POAG. PDW is positively related to the severity of the disease. There is a report said the increase in PLT occurring in the coldest month, but also find an increase in the summer with a consistent influence by geographic variation in China. Indonesia only has 2 seasons, and there is no data related to variation in platelet value with seasonal change in Indonesia. Knowing of the photomechanism of POAG in relation to platelet parameters, so through this study, we can develop additional predictor examination strategies to assess the severity of POAG. This is an observational analytic cross-sectional study perform measurement of platelet parameters in POAG patient at the same time period. This research was conducted at Sanglah General Hospital. The time for research to be carried out start in July 2021 until the number of research sample is fulfilled. Inclusion criteria, which is patient with primary open-angle glaucoma, is more than equal to 40 years, and patient with POAG who have not received or have received medical therapy. For the exclusion criteria, patient with hematological disease, patient with abnormal clotting function, with severe cardiovascular, liver, kidney disease, with history of previous surgery or trauma, patient with acute infection disease, and patient with use of antiplatelet drugs in the last 6 months. As the result, the most sample is male, which is 70.6%, and with glaucoma moderate to severe degree. The analysis of relationship between PLT and the severity of POAG, there is no relation. There is no relation between PDW and the severity of POAG, and there is no relation between MPV and the severity of POAG. From multivariate analysis of relationship between platelet parameter, age, IOP, CCT, and severity of POAG found age have relation with the severity of POAG. Meta-analysis for 20 years said that prevalence of POAG 84.4% in men. Men are more susceptible to POAG than women with a relative risk of 1.28. In this study, 70.6% is male. The exact reason is still unclear, but some studies said men's axial length is longer and anterior chamber depth is deeper. So this is the potential reason. Average age is 66.71 years. POAG prevalence increased with age. So aging per decade is associated with higher IOP and thinner CCT. So this is the major contributing factor to higher prevalence in POAG in the elderly population. In this study from bivariate analysis, the three parameters of platelet have no relation with the severity of POAG. Watanabe et al. Said that improvement of platelet coagulation and inflammation of the slime canal endothelium in POAG patient. From Nishijima said that platelet actively interact with retinal endothelial cell in the post-ischemic retina. Ma et al. Said that there is no relation between PLT and RNFL thickness and ganglion cell complex in patient with POAG. There is no difference in PLT and PTW value between PAGG patient and control group. But in the two studies above, it was not explained the detail. The reason for not finding relation and difference between platelet parameter in the study subject was not clear. From multivariate analysis, there is positive relationship between platelet parameters and the severity of POAG, but the p-value was more than 0.05. Ma et al. Said that PDW and MPV levels is higher and PLT levels is lower in the group of POAG compared to control. Li et al. Said that PDW and MPV increase in patient with neovascular glaucoma and PAGG. So this is estimating changes in platelet activation in patient with POAG and also in disease progression. In this study, there was no statistical significance between platelet parameters and the severity of POAG. Peng et al. Said that there are differences in the number of platelet and MPV in different provinces between North and South in China, caused by temperature variation in different geographical area, where the North is lower when compared to the South. So PLT is higher in summer, while MPV is lower. But Elwood et al. In the same country said that increased PLT that occurs in the oldest month. Various conditions can affect the number of platelet parameters such as ethnicity, climate and weather, season, and geographical condition of a country. So, and also the use of anti-glaucoma drugs like carbonic anhydrase inhibitor will suppress the bone marrow. In this study, most subjects receive various anti-glaucoma drugs for various length of time. So it is possible that this condition also contributed to the difference in the result of the platelet parameter value. Patients with age more than 68 years is 9.85 times have the risk of developing glaucoma with moderate high degree severity compared to age lower than 68 years. Karandikar et al. Said that patients with mild glaucoma are significantly younger, and age is associated with 56 increase in the likelihood of severe glaucoma per decade compared to mild glaucoma. Increased CTR and narrowing of the visual field are in accordance with the progression and increase in the duration of glaucoma. So patients with older age and longer duration of glaucoma have more severe glaucoma. As conclusion, in this study, there was no relationship between platelet parameters and the severity of glaucoma. There is a relationship between age and the severity of POAG, where older age is at risk experiencing moderate severe POAG severity 9 times greater than younger age. Many factors affect the severity of POAG and the condition of a person's platelet, which is geographic, climate and weather, temperature, use of the systemic drugs, and anti-glaucoma drugs. Thank you, Doctor.
Yeah, thank you, Dr. Abdi, for the presentation. Now we continue to the 2-minute Q&A. Dr. Abdi will, Dr. Fitrato will give you a question, and I will cut if you answer more than 2 minutes. Yeah, okay, please, Dr. Fitra.
Okay, thank you, Dr. Vivian. Dr. Abdi, thank you for your presentation. Maybe I want to know about your main reason of your study. Why do you make correlation platelet with a primary open-angle glaucoma?
Okay, thank you for the question, Doctor. So for the first, platelet, which is a part of complete blood count, is a quite usual examination we do in many hospitals. With there is several authors said that there is correlation between especially platelet parameter, which is in PLT, PDV, and MPV, said that they have a correlation with the severity of glaucoma. So I think if we can make sure, or if the study can show that, oh, that's correct, platelet parameters have relation with the primary open-angle glaucoma. So in the hospital or in the center that have no such examination like OCT to make sure the severity of the glaucoma, they can use this examination, they can use this complete blood count to minimal to approximating what about the prognosis of the patient? No need to send to the hospital that have an OCT or another examination that needed as an indicator to show that glaucoma is severe or moderate. What about the prognosis? So with complete blood count only can predicting the severity of primary open-angle glaucoma.
Okay, thank you. It's enough, Dr. Vivian. Thank you.
Thank you, Dr. Fitra.
Thank you,
The
Doctor.
time is up. Okay. And then we proceed to our second contestant, Dr. Rofa Husnul Huluki. Are you already in the room? Dr. Rofa?
Assalamualaikum, Dokter.
Waalaikumsalam. Okay. Are you ready?
Yes, I'm ready.
Okay. Yeah, committee, this you can prepare the video recording.
Assalamualaikum warahmatullahi wabarakatuh. Good afternoon, dear judges and colleagues. My name is Rofa Husnul Huluki, ophthalmology resident from Universitas Brawijaya Malang. Today, I will be presenting our study result entitled Central Corneal Thickness of Metabolic Syndrome, Non-Metabolic Syndrome, and Different Body Mass Index Population. The corneal endothelium play a major role in maintaining optical transparency of the cornea. Central corneal thickness is a corneal parameter in determining the corneal barrier and endothelial pump function. It is affected by various disease or genetic abnormalities, including metabolic syndrome. Central corneal thickness is important since it is an essential part of the evaluation of candidates for refractive or cataract surgery, as well as in patients with glaucoma or corneal disease. Metabolic syndrome is a cluster of disease, including central obesity, dyslipidemia, hyperglycemia, and high blood pressure. It is estimated that around 20 until 25% of the world's adult population have the metabolic syndrome, and they are twice as likely to die from and 3 times as likely to have serious complications, including blindness. Metabolic syndrome may cause eye damage through oxidative stress, endothelial dysfunction, and inflammation. The association of diabetes and hypertension with CCT change is well known, but the association of metabolic syndrome with CCT change is very limited and inconsistent result. So we have conducted a study to compare CCT value in metabolic syndrome and non-metabolic syndrome patient, and to also assess how significant the difference of CCT value in metabolic syndrome and non-metabolic syndrome patient in our population study. This was a population-based cross-sectional study conducted in 3 rural areas of Malang and approved by Ethics Commission, Faculty of Medicine, Universitas Brawijaya Malang. Written informed consent was obtained from all participants. We include participants with this following condition: those with incomplete examination and have more than 2 micrometer standard deviation of USP result. Also, those who were pregnant were excluded from study. After obtaining informed consent, we perform blood pressure examination, anthropometric examination, blood tests, anterior segment examination, and CCT measurement. All CCT data were reported as means and standard deviation. We present the other descriptive data as frequencies and percentage. Difference in CCT between metabolic syndrome and non-metabolic syndrome, BMI, gender, and age were assessed using Mann-Whitney and Kruskal-Wallis. All analyses were performed in SPSS version 25. The study enrolled 890 participants. Majority of our study population were females, most of them aged 50 until 59 years and have overweight BMI. In our study, only 44.9% participants have metabolic syndrome. As there was no statistical difference between CCT measurement of the right and the left eye, only the reading of the right eye were used for analysis. Comparative analysis in CCT between metabolic syndrome and non-metabolic syndrome group in our study revealed significant difference. CCT was found to be thicker in metabolic syndrome. This result was in line with study by Su et al. Meanwhile, Sahinolu et al. Revealed no correlation between metabolic syndrome with CCT in their study population. The main reason of metabolic syndrome having thicker CCT is remain unclear, but there's a hypothesis that metabolic syndrome may alter the physiology of the corneal endothelium, which causes an increased CCT. Comparative analysis in CCT between gender in our study revealed significant difference. CCT was found to be thicker in women. These results were in line with study by Fortepiani et al. And Pran et al. However, different result was revealed by Suzuki et al., Beijing I study, and Vijay et al. In this study, CCT was found to be thicker in men. The cornea of women can be influenced by hormonal changes that occur during monthly menstrual cycle. Many previous reports showed that men had thinner cornea than women. This difference was attributed to active environmental influence of the human cornea, resulting in thinner cornea in men. All other reports that have detected gender differences have also shown women having thinner cornea than men by approximately 7 until 8 micrometer. Comparative analysis in CCT between age group in our study revealed significant difference. CCT was found to be decreased with age. This phenomenon also reported in other population-based study by Hassan et al., Han et al., Nemesur et al., and Hercieca et al. Meanwhile, Kamiya et al., Reykjavik I study, and Prasad et al. Didn't find any association between CCT and age. This age-related difference, supported by histologic evidence, is that older individuals have thinner CCT because of the decline in the density of keratocyte and probable breakdown in the collagen fiber in the aging cornea. Longer exposure to the environment may also affect the structural integrity of the cornea, resulting in thinning of the cornea with age. In addition, poor nutritional status and malnutrition in elderly can also affect the lack of nutrition of the cornea, which result in thinning of the cornea in elderly. Comparative analysis in CCT between BMI group in our study revealed significant difference. CCT was found to be increased with increasing BMI. These results were in line with study by Su et al., Nishituka et al., Mechiecha et al., Kamiya et al., and Stinson et al., and Prasad et al. However, different result was revealed by Kunz et al. In the study, increasing BMI is not associated with increased CCT. The reason for this association remain unclear, but are thought to be related to dyslipidemia and race. The strength of the study is population-based with a large sample size. The limitation of our study is the use of comparative analysis because it cannot describe the relationship between the CCT with other variables. Confounding factors such as curvature of cornea and IOP, which affect CCT measurement, also not being analyzed in this study. As a conclusion, we found individuals with metabolic syndrome had thicker CCT, individuals with obesity had thicker CCT, and women and younger individuals have thicker CCT. We suggest further studies in the form of cohort studies or clinical trials with multivariate analysis and larger sample size. This is the end of my presentation. Thank you so much for your kind attention. Assalamualaikum warahmatullahi wabarakatuh.
Yeah, okay. Thank you, Dr. Rufa. Nice presentation. Yeah, I will ask you maybe one or two questions. You already mentioned about the confounding factor of this study. I want to know how you handle it. Do you analyze the confounding factor also that maybe influence your result? And the second, maybe what is the you already mentioned the weakness of this study. So what is your station if someone or maybe you want to do this study again? Can you hear me?
Yeah, thank you so much for the question, Doctor. I would like to answer. I will try to answer the first questions. The confounding factor, actually, we didn't handle it because we didn't measure the IOP and the curvature of cornea because we are very limited in the tools, the equipment. We don't use it, so we don't measure it. And then the second question,
limitation
about this
the limitation of the study.
Okay,
the limitation. If you want to repeat or anybody want to do this study like you.
Yeah, we suggest the study will be the further study will be the cohort study maybe, and maybe we can use the analysis like correlation analysis to find the relationship between these two parameters. Yeah, because with comparative analysis we cannot measure the correlation between the CCT and the metabolic syndrome. That's all.
Yeah, I think it's okay. Yeah, okay. Thank you. We will
Thank you so
proceed
much.
to the next contestant with Dr. Azahra Afifa. Dr. Azahra. Are you already in the room?
Yes, doctor.
Yes. Okay, are you ready?
Yes.
Yeah. Dr. Alfia, you will prepare the presentation.
Hello, professors, doctors, and judges. My name is Azahra Afifah. The presence of artificial intelligence in this modern era is able to provide convenience in the health sector, which can be used as a method for detecting keratoconus to prevent underdiagnosis of this disease. On this occasion, I will present my paper with the title Artificial Intelligence as Diagnostic Modality for Keratoconus, a Systematic Review and Meta-Analysis. Artificial intelligence, or AI, has been utilized to enhance diagnostic management and guide treatment. In keratoconus, both eyes have progressive and asymmetric ectasia corneal disease that characterized by abnormal thinning and bulging of the cornea, resulting in severe vision impairment and dependence on visual aids. AI has been developed to diagnose keratoconus, but the challenges present the need for clinical science, uniform screening criteria, and low disease prevalence. But AI can assist in capturing most of the pertinent clinical elements complex data, providing prior interpretable outcomes and choosing appropriate treatment strategies. So, this study aims to analyze the accuracy of keratoconus diagnosis following its classification and the AI model use. We use Prisma with these combination words in PubMed, Medline, and Science Direct with previous 5 years in English, not case reports, and using AI to diagnose keratoconus. Risk of bias follow Quadas 2 with Review Manager 5.4 tool, and then we fit with a curve hierarchical summary receiver operating characteristic, and this study represented by a summary point. We identified more than 300 records in databases, and we retrieved more than 200 records, and then we screened and we retrieved 119 studies. Based on inclusion criteria, we retrieved 11 eligible studies for the analysis. We review 11 studies and categorize them into early keratoconus from controls, keratoconus eyes from controls, and keratoconus severity. 7 out of 11 studies were evaluated with a high risk of bias, while the remaining studies were either unclear or had low risk. Meta-analysis was conducted on 6 of 11 studies, while 5 studies were omitted due to insufficient data for calculating accuracy. Neural network is the most used AI model in diagnosing the keratoconus with the highest sensitivity of diagnosing keratoconus, which obtained from Kamiya, and the highest specificity which obtained by Tan et al. The second most used AI model to detect keratoconus is random forest. 2 studies investigated random forest as AI algorithm to compare keratoconus from normal eyes, with the highest sensitivity and specificity from Chow et al. 1 study in naive bias to evaluate normal and keratoconus with the highest sensitivity and specificity of 1 respectively. As we can see, the curve showed the sensitivity and specificity more than 0.9, with the overall performance of AI model has shown significant results. AI can be reliable in differentiating keratoconus eyes from control eyes. The study conducted by Chow et al. Showed that the algorithm has significantly low sensitivity and specificity compared to other AI models. These results differ from a study conducted by Valdez et al., which found the best result from all models in line with Tan et al. Our research found the neural network as the most frequently used AI model for diagnosing keratoconus with high accuracy. Naive Bayes have one sensitivity and specificity in line with Lewis et al. That Naive Bayes had the best result compared to other algorithms for keratoconus detection. Random forests have sensitivity and specificity more than 0.9 in line with Lopez et al. That found the random forest had the best performance in detecting subclinical eyes. Attila also discovered random forest has the highest classification performance. Conclusion of this study to present the prospect of using AI models to diagnose keratoconus. The AI model with the highest sensitivity and specificity detection are neural networks and naive Bayes. The main objective of AI in the healthcare services is to support clinicians in making medical decisions concerning patients. And keratoconus diagnosis should be distinguished the early keratoconus and the high keratoconus stages for giving the appropriate treatment. This study is limited to conducting a meta-analysis on one AI model for each study, which is further systematic review are suggested to search for more studies to provide more comprehensive results. It is also recommended for the clinician to determine the most appropriate inputs for each AI model. However, despite all the limitation, this study has significantly contributed to providing evidence of AI accuracy as a diagnostic modality. With AI, it is hoped that it can help to screen the disease with low prevalence like keratoconus. Thank you.
Yeah, thank you, Dr. Azahra, for the presentation. Now we proceed to Dr. Fitra to give a question for Dr. Azahra. Dr. Fitra, please.
Thank you, Dr. Vipin. Dr. Azahra, you can hear my voice?
Yes, doctor.
Okay. Yeah, Dr. Keratoconus. Dr. Zahra, can we do this test for another patient beside keratoconus?
Thank you for the question. In this study, we focus on keratoconus only, and in the previous study also can for the other eye disease, doctor.
So according to you, beside keratoconus, will test give the more beneficial or not?
Yes.
Or just okay.
Yes, doctor. As we know that keratoconus is a progressive corneal disorder that can lead a significant visual impairment if not diagnosed and managed appropriately. So, underdiagnosis of keratoconus can occur due to various reasons, including limited access to specialized eye care services, lack of awareness, and absence of routine screening programs. And in many cases, keratoconus is initially misdiagnosed as astigmatism or other refractive error, so leading to delay or misdiagnosis. So the condition may only be identified at a later stage when significant corneal thinning and irregular astigmatism become apparent. So to address the underdiagnosis of keratoconus in Indonesia, efforts are needed to improve awareness among healthcare professionals and the general public about signs, symptoms, and risk factors of keratoconus. Now, with the rapid development of technology, the presence of artificial intelligence can be used and positive things. And in Indonesia, that is a real example. FKUI joined with RSCM AI-based software to detect COVID-19. So I believe this study like this Indonesia can open up our new insights so that the health
Dr. Azahra, I think
can continue.
Okay, thank you. Thank you, Dr. Vipin.
Yeah, you're welcome. Okay, we proceed to the, I don't know, is this the last contestant or not? Dr. Christy Magdalena, are you already in the room?
Yes, I'm here. Good afternoon.
Yeah, are you ready?
Yes, I'm ready.
Yes, okay. Dr. Afia, please, the video recorded.
Good day, everyone. My name is Christy Magdalena, and I'm going to present our study entitled Adherence to Ophthalmology Referral Following Diabetic Retinopathy Telescreening in Jakarta. Every 1 in 3 people with diabetes mellitus develop diabetic retinopathy, with a global prevalence of 34.6% for DR and 10.3% for vision-threatening DR. Indonesia is projected to rank fourth for the prevalence of diabetes mellitus in 2030, and as one of the complications, DR will also follow this trajectory. DR-related visual impairment brings detrimental effects on independence, mental health, and productivity. On the national level, DR management in Indonesia costs up to 2% of the 2017 national budget. This makes DR a concerning health threat, which warrants an established screening program. And to achieve its goal, adherence to referral for treatment and follow-up following diabetic retinopathy screening program is one of the key elements of a successful DR screening program. With this study, we aim to determine the level of adherence of patients to ophthalmology referral after DR telescreening in primary health centers in Jakarta. This study was a part of DR prevalence research in Jakarta, and we conducted a telephone survey by contacting 458 patients with reversible conditions within 2 to 12 months after grading results were returned. We excluded patients who did not respond after 3 call attempts and 1 message. In this study, we determined first the level of adherence by later categorizing patients into complete or incomplete referral groups for patients who had or had not visited ophthalmologists at the time of survey, respectively. We also described their characteristics and also listed all the barriers to adherence and later categorized them into patient or non-patient related barrier. The response rate of our telephone survey was 42.8%. However, of all the contacted patients, only 37.2% of them were advised for referral by their GPs. Patients in our study also demonstrated a high level of adherence, 86.3%, and this is very much higher than rates reported in other studies, ranging from 29.5 to 60%, and most of them were conducted in rural and underserved communities which possibly had resource constraints to adhere to referral. The complete referral groups had more severe forms of diabetic retinopathy, and they had worse presenting visual acuity. A similar study in China cited that 45% of patients reported unaffected visual function as one of the barriers from completing referral, and this shows a significant knowledge-related barrier among patients. Unfortunately, 62.8% reported that they had not been informed of the screening recommendations by their GPs. This shows the significant presence of non-patient-related barriers, which merits further investigation. 2 of the most commonly cited non-patient-related barriers were cost and insurance ownership. However, these 2 patient-related barriers were not reported by our patients, as most of them were insured or covered by Jaminan Kesehatan Nasional. This is evidence that insurance ownership is one of the enabling factors for adherence. Our study is limited by several factors, and one of them is the long interval between screening and recommendations, which took around 1 month, and elimination of this interval could hopefully enhance completion of referrals. There was also a possibility of recall bias and social desirability throughout the telephone survey. To summarize, patients demonstrated a high level of adherence following DR telescreening in primary health centers. Patients who had more severe forms of diabetic retinopathy and experienced more visual symptoms had a greater tendency to adhere. With improvement in the model and removal of barriers, telescreening could be the future of systematic diabetic retinopathy screening in Jakarta. That's all for the presentation, and we would like to thank you for your kind attention.
Oh, Dr. Christy, yeah, for the nice presentation. Yeah, you already do the study, and you also know how is the result. Do you have any idea to? I think not satisfied enough, is it? The result of the study, is it satisfied for you?
Thank you for the question, Doctor. In regards to the compliance rate, I think the compliance rate is quite satisfying for the health system. However, I realized that that cannot be extended to every area in Indonesia. So we have to take a very cautious conclusion from this result, because every area has a different infrastructure, also different health systems. So we have to take this result and conclusion very cautiously. So yeah, in regards to compliance rate, it is satisfying. However, if I can say that, I hope that we can elaborate more on in regards to why some patients were not informed by their GP in regards to their screening results. I think that's the answer, Doctor.
Do you have any idea after do you have any idea or opinion to increase the awareness about the screening of diabetic retinopathy or other eye disease maybe after you are doing this study?
To increase the awareness of the patients, doctor. Is that what you mean?
Not all patient. Whoever terlibat in this program.
Right. Yeah. I think it's a very challenging situation because screening we cannot see the threat, the health threat. So I think that we need to remember that every disease has actually unforeseen complications that can actually build up as an iceberg of mountain because we can only see the tip of the iceberg. I think that's one thing that we have to emphasize to every health sector.
Okay, thank you. Very nice answer. Yeah, thank you. Okay, time is off. Okay, I think we have already finished with 4 contestants, yeah, Dr. Fitra. Can we, Dr. Alfia?
Yeah, Doctor.
We still have another presenter?
Yes, there's one presenter, Dr. Agung Pujono.
How about the time?
To invite him into the room.
How about time? Still enough? Okay.
Yes, we still have half hour.
Yeah, I think Dr. Fitra, are you agree if we invite the next presenter from the waiting room?
Okay, how many speakers?
One, doctor.
Yeah.
One.
One. Yes.
Okay, yeah. Okay, yeah.
Dr. Agung Fujiono.
Dr. Agung. Oh, yeah. Agung Fujiono.
Yes.
Already joined with us?
In the process.
On process.
Welcome to Dr. Agung Fujiono. Can you please rename your Zoom account? Yes, thank you.
Yeah. Dr. Agung Fujiono. Are you in the meeting room? Zoom room? Dr. Agung?
Yes, ma'am.
Yes. Are you ready for the presentation?
Yes, I'm ready.
Welcome, even you are ready. Yeah. Dr. Afia, you will prepare the presentation.
Greeting. My name is Agung Fujiono. In this opportunity, I would like to present my study about knowledge, attitude, and behavior of patients and families regarding corneal donor and output in outpatient clinic of a tertiary hospital. The majority of cases of corneal blindness can be rehabilitated with a corneal transplant. However, the level of donor cornea in Indonesia is still insufficient to meet the needs for corneal transplant. Based on the registration of the Central Indonesian Eye Bank from 2013 to 2016, there were about 170,000 people who needed corneal donors. Meanwhile, only 14,000 people were registered as a donor and only 142 donor cornea were acquired in that period. The availability of donor cornea in Indonesia is not in line with the ever-increasing need. In addition, donor cornea that come from import tends to be more expensive. The purpose of this study was to determine the relationship between socio-demographic factors, knowledge, and attitude toward people behavior regarding corneal donation. The study used a cross-sectional study design. This research lasted from September 2021 to December 2022. This research was carried out at the Cito Mangunkusumo Hospital, Jakarta. The inclusion criteria applied to the study were patients or family of patients at Cito Mangunkusumo Hospital who were over 18 years old and willing to become research subject by agreeing to informed consent. The exclusion criteria applied were unable to fill in the questionnaire and unable to read. While the criteria for dropping out in the study were respondents who had filled out the questionnaire but withdrew as research subjects, and respondents who filled out the questionnaire but were incomplete. The research flow in the study: first, we compile a questionnaire and validate content with experts so that a final questionnaire is formed, receive approval from the Ethics Committee of the Faculty of Medicine, Universitas Indonesia, and permit from research location in the Cito Mangunkusumo Hospital environment. Then we conduct a pretest using a final questionnaire, and then we test the validity and reliability of the questionnaire based on the result of the pretest to form the final questionnaire used for data collection. The final questionnaire that had passed the validity and reliability test was then distributed to outpatient clinic within the Cipto Mangunkusumo Hospital. There were 453 respondents who met the inclusion criteria with a survey participation rate of 90.6%. There were no respondents who had dropped out, so that calculated respondent data was included in the data analysis as research subjects. The data obtained from the questionnaire is entered into the main data table, then data processing is carried out using SPSS version 25.0, and then we reporting the research result. The subject of the study were mostly the patient's family. We fill out the questionnaire during a visit to the outpatient clinic to accompany their relative for treatment. Female subjects were found to be slightly more than males. Gender distribution in this study is almost the same as the 2021 population census in general. In Indonesia, adhered to a patrilineal system where men play a greater role as decision maker in family. Age in this study was slightly different compared to other study by Palomar et al. And the subject with the various age range are interesting to explore, considering that donor cornea are taken after the donor has died. With increasing of life expectancy, of course, donor at a young age will need longer time to be able to provide the corneal tissue. The religion of the subject in the study is predominantly Muslim. This is in line with the majority of religions adhered to the majority of Indonesia's population. With the highest number of the subject ethnicities in the study is Javanese, and the married group are the majority group. This is in line with the research by Fisher et al. In the city of Gondar. The patrilineal system that is implemented in Indonesia more or less also has a role in decision making. Although women will before marriage has the independence to make their own decision, but after marriage many leave decision making to their husband. This is also very possible in making the decision to donate their corneal tissue. The subject in the study must were high school. This is in line with the research of the Hussein et al., where the majority of the subject also completed their education up to high school. On the other hand, non-medical education in the study was more dominant. This educational status can be used as a guideline in designing a community education program to increase individual knowledge and willingness to become donors. Educational material delivered to the public should be made easy to understand and adapted to the level of education of the community in population. Using chi-square test, there is a relationship between knowledge and behavior as a donor. By increasing knowledge, it can significantly increase good behavior as a donor. This is similar to the research by Chen et al. And Wang et al. Based on the analysis in the study as well, attitude have a relationship with behavior. Meanwhile, based on research by Rao et al., there is no relationship between attitude toward behavior as a donor. In addition, there is no relationship between knowledge and behavior. In Rao et al. Study, even though knowledge and attitude gave satisfactory result, the result of measuring behavior were considered low. This study also assessed the relationship between socio-demographic variable and behavior. The result of the Mann-Whitney test analysis to assess the relationship between age and behavior found that behavior in the good category was found at median age of 39 years, while behavior in the like category was found at a median age of 35 years. Statistically, there is no relationship between age and donor behavior, with p-value 0.3. Relationship of other demographic characteristic to donor behavior. Statistically, there was a relationship between each group of socio-demographic characteristic to donor behavior in almost all demographic characteristic groups, except for the marital status group, field of education, and occupation. In this study, further analysis was carried out to find out which of the socio-demographic component, knowledge, and attitude had the most influence on the behavior of corneal donor. Based on the result of multivariate analysis, there were three socio-demographic components, which is gender, corresponding category, and religion, in addition to knowledge and attitude variable, which were thought to influence the behavior of corneal donors in the subject observed. From the result of logistic regression analysis in the study, also obtained a constant predictive value of corneal donor behavior. Based on this analysis, it can be assessed a probability for someone to become a donor by considering the variable of knowledge, attitude, category of patient or patient family, religion, and gender. Thank you for your attention.
Thank you, Dr. Agung. Next, Dr. Fitra, your question, please.
Okay, thank you, Dr. Vivin. Dr. Agung, interesting about your study. I want to know what your reason for entering religion in your study. You find Muslim the most common case, yeah? What is your reason you entering this parameter?
Okay, thank you, Doctor. In this study, I entered the religion to compare the difference between with another study in Gondar and in India. So in this study, I get the result that the majority of the respondent there is same with the majority religion that the sample took place. It is similar with another study in another country that the majority in the same study is the majority in the religion in that place. And besides, I took the Muslim category because in this the majority in the subject majority are in Javanese, which is the Muslim are the larger in the Java. So I take what is the belief for the corneal transplantation. So and the result are amazingly that they are delighted for doing the transplantation.
Okay, I think it's enough, Dr. Pipin. Thank you.
Yeah.
Thank you,
Still,
Dr.
you still have this time, Doctor? Ini still 5. Oh, okay. The time is up.
Thank you, Doctor.
Okay.
Yes.
Yeah, we already finished with 5 contestants. So, Dr. Afia, how about Dr.
Yes, Doctor.
Okta?
There's no other
Still not
participant waiting in
joined?
the waiting room. Probably she's not
Okay.
joining the session, Doctor.
Okay. So
Not
we
joining
can
the session.
finish and close
We
this
finish
Yes.
session,
meeting.
Afia.
Yes,
Yeah.
Doctor.
Thank you again. Yeah, okay, thank you again to the contestant, also especially to the judges, Dr. Fitratu. Thank you for the time to be a judge in this meeting, in this contest competition. And I will close this meeting. Thank you again to all the participants and also to committee. Yeah. Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh.
Terima kasih banyak.
Waalaikumsalam,
Ya.
Dokter.
Waalaikumsalam warahmatullahi wabarakatuh.
Terima kasih,
Silakan lead
Dokter
peserta
Fitratu dan Dokter
contestant.
Christian.
So we're both going to lead the session. So without further ado, we're going to have 6 presentations today. So I think we can just start with the first presenter, Dr. Nur Aisyah Rahmawati, Inaso PRS FP GR30. Time is yours.
Assalamualaikum warahmatullahi wabarakatuh. Thank you for the opportunity. I am Nur Aisyah. I would like to present my paper, a 5-year retrospective study entitled Successful Management of the Challenging Cicatricial Ectropion with Full Thickness Skin Graft. For the introduction, cicatricial ectropion is associated with anterior lamellar shortening and secondarily occurs to diverse etiologic factors such as trauma and infection. This is the pictures of cicatricial ectropion cases in our center. Major morbidity of cicatricial ectropion is the exposure of conjunctiva and cornea, causing long-term ocular complications, thus potentially threatening visual function. Surgical management consists of full thickness skin graft combined with other procedures depending on the condition and severity. This study aims to evaluate the outcome and complications of surgical repair of cicatricial ectropion. Design of the study is retrospective cohort, with the inclusion criteria of cicatricial ectropion patients that underwent correction surgery in Kirana Cipto Mangunkusumo Hospital from January 2016 until December 2021, done by 4 surgeons. This study has been approved by ethical committee. Success criteria is divided into 2, which is anatomical and functional. Anatomical success is no recurrence, overcorrection, and undercorrection. Functional success is improvement of symptoms and physical appearance. Complications is the incidence of side effects. Recurrence is when the ectropion reoccurs post-operatively after success was achieved in the initial correction, starting 2 weeks post-operatively. Undercorrection is residual ectropion that was found within 2 weeks. Patient must be followed up at least 2 weeks to be included in the success analysis. We move to results and discussion. 31 eyes from 29 patients were included in the study. McKelvey in NC found 55 eyes in 5 years. And meanwhile, Amartya in India got 17 eyes in 2 years. This may be due to anatomical differences, which ectropion is more commonly found in non-Asia than in Asia. Mean age was younger than previous studies by Galatoir and McKelvey. In the study, mostly the etiology was mechanical trauma, which more similar in study by Early that found the mean age was under 50 years old. Ectropion was more commonly found in males. Unilateral cases is more commonly found. Median onset is 6 months, which can be caused by socioeconomic factors or mild clinical symptoms in early case. Watering and poor appearance were the most common presenting symptoms. Most of the initial vision was in the normal group, which might be one of the factors the patient did not immediately seek treatment. The most common etiology is mechanical trauma. As found by Chua et al., that the most common etiology in Asian population is mechanical and postoperative trauma. Meanwhile, in case series in non-Asian population, the most common etiology was actinic skin damage. A total of 26 eyes underwent a follow-up examination at least 2 weeks. The surgical procedure was mainly a full-thickness skin graft with lateral cantopexy and cantoplasty. This is the intraoperative picture. Type of procedures depend on the condition and severity. In cases with small traction and linear cicatricial, G-plasty was done. Meanwhile, skin graft was done in cases with diffuse scar and severe traction. Horizontally tightening could be added to improve results anatomically if there is laxity. In general, this result in line with studies conducted by McKelvey, Miletic, Amartya, and Galatoir, that the type of horizontally tightening procedures varies depend on the condition. In 81% of patients, satisfactory anatomical and functional outcome was achieved with a single surgical procedure, much higher than in the past published study by McKelvey and Worley et al. This may be due to the surgeon's experience in handling cases at the tertiary hospital. Unfortunately, the length of the follow-up was not quite long. There were no significant complications perioperatively. Ectropion recurrence and undercorrection occurred in 2 and 3 cases respectively. Only 1 case with severe ectropion needed additional surgery, and the other was well managed with intralesional triamcinolone injection. In conclusion, majority of the patient in this 5-year retrospective study is male with mean age of 39 years old with mechanical trauma as the most common etiology. Full-thickness skin graft is the treatment of choice for cases with diffuse scars and severe traction, combined with horizontally tightening depends on the laxity severity. As a complication, cicatricial ectropion surgery remains challenging and requires detailed and adjusted treatment. Most patients could achieve satisfying outcomes with a few minor complications, therefore improving the patient's quality of life. Thank you. Wassalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh. Thank you, Dr. Nur Aisyah. Maybe Dr. Chut Samira, would you like to comment on a few things?
Okay, thank you, Dr. Ratufuri. I have a couple of questions for the Dr. Nur Aisyah. The first one is, what do you think the limitation or the weakness of your study? And what do you think you can do better for the next study if you want to continue this study? What will you do? What will you change? Either the inclusion or exclusion criteria or the method of operation that can make your study better? Thank you.
Thank you, Dr. Chut, for the question. For the first question, with the limitation from my research is that the first one is the about the length of the follow-up. The length of the follow-up in this analysis, we only included for 2 weeks minimal. Meanwhile, for the much better results, we must follow up minimal in 1 month, and after that in 3 months, and also 6 months after the surgery. And the second is to report the this is the retrospective study, so the
the nature of the study is the not so similar from the reporting, such as in eyelid examination and also the etiology and also for the surgery. So we have to give the same treatment and also the same yes for the pencatatan.
Recorded data.
Yes, for the recorded data. Thank you.
Okay, any other thing you want to add as any other limitation that you think might influence your study?
Yes, such as the minimal sample and also the minimal follow-up and the retrospective nature study.
Thank you.
Okay, thank you. I think time is up. So thank you so much, Dr. Nur Aisyah Ramawati, for your presentation. So we'll move on to the second presenter, Dr. M. Dio Syaputra in CRS FPGR 16.
Hello everyone, let me present my study, Comparison of Visual Acuity and the Focus Curve After Cataract Surgery with Pure Extended Depth of Focus Lens and Mini Monovision, Interim Analysis. Cataract surgery is the most frequently performed surgical intervention in the world as the number of elderly population increases. Nevertheless, presbyopia after cataract surgery is still a problem. Surgical techniques and IOL designs have continued to develop to meet patients' high expectation, not only to see clear at distance, but also at intermediate and near distance. Mini monovision technique and pure EDOF lenses are relatively low-cost alternatives. Mini monovision achieve multifocal ability from the difference in the refractive target between the two eyes. Meanwhile, EDOF lens design creates an elongated focal point. Intermediate vision is crucial as it is used in daily activities. The purpose of this study is to compare the clinical outcome after cataract surgery with binocular mini monovision and cataract surgery using a pure monocular EDOF lens. Subjects were randomized into each group and the clinical outcome examiners were masked. This is the inclusion and exclusion criteria. Here are the results. Each group consists of 8 subjects with similar mean age 64 to 65 years. Presenting visual acuity showed moderate to severe visual impairment, which can lead to decrease in quality of life, impact on mental health, and increased risk of fall and even fracture. No significant difference in preoperative clinical characteristic between two groups. No significant difference in biometric parameters. No significant difference in postoperative clinical characteristics. There was no significant difference in uncorrected distance visual acuity of both groups. Similar to previous studies, it shows that both groups did not result in decreased distance visual acuity. There was statistically significant difference in uncorrected intermediate visual acuity between binocular mini monovision and monocular EDOF group, 0.10 logmar and 0.19 logmar respectively, but clinically not significant as it is less than 10 letters. All subjects in mini monovision group had binocular uncorrected intermediate visual acuity of 0.10 logmar or better. This result showed that mini monovision techniques allow patients to perform intermediate distance activities without spectacles. Meanwhile, in EDOF group, 62.5% subjects achieved monocular uncorrected intermediate visual acuity of 0.20 logmar or better. Uncorrected near visual acuity between two groups was statistically and clinically significant, 0.26 logmar in binocular mini monovision and 0.54 logmar in monocular EDOF group. Each study group had similar results to separated previous studies. This is the focus curve of binocular mini monovision, blue line, and monocular EDOF, orange line. At the focus lens minus 2.5 diopters, which is equivalent to 40 centimeters or near distance, binocular mini monovision was significantly better than monocular EDOF. Is statistically and clinically significant as the difference was 0.20 logmar. The focus curve of binocular mini monovision in NASA study showed visual acuity of 0.20 logmar or better at 50 centimeters to infinity compared to 0.20 logmar in our study. This graphic shows comparison of the focus curve between dominant eye of mini monovision, blue line, and non-dominant eye of mini monovision, gray line, and EDOF, orange line. At minus 1 diopters and minus 1.5 diopters, the focus lenses, or 67 to 100 centimeters distance, EDOF was better compared to dominant eye of mini monovision using monofocal lens. These findings consistent with Unsal and Menchuchi study with p-value less than 0.05. They're showing that intermediate vision was better in EDOF lens than standard monofocal lens. Meanwhile, the focus curve of non-dominant eye of mini monovision using monofocal lens versus EDOF at plus 0.5 diopters, 0 diopters, and minus 2.5 diopters, the focus lenses, mini monovisions was better. It is matched the target refractive of dominant eye that was intentionally made more myopic. We concluded that uncorrected intermediate visual acuity and uncorrected near visual acuity were better in mini monovision than EDOF group, and at the focus lens minus 2.5 diopters or 40 centimeters distance, mini monovision group was better than EDOF. Despite this interim analysis research power of uncorrected intermediate visual acuity and uncorrected near visual acuity was more than 90%, number of subjects in our study was smaller compared to previous studies, so further study is needed. Thank you.
Thank you so much, Dr. Dio, for your great presentation. I'd like to ask a few questions. The first one is, what is the background of your study that you want to know whether a monocular EDOF, why not a binocular EDOF? That's the first one. And do you find there is any specific criteria for the patients who is going to do well with both of this group, I mean monocular EDOF or mini monovision?
Okay, thank you, Doc.
Thank you.
For the first question, I would like to answer why I choose monocular EDOF is due to this. We would like to compare the IOL designs and the technique of the surgery. I mean, like in mini monovision, we need two eyes to make the binocular vision that can make distance or elongated visual acuity. And with monocular EDOF, we make the distance or elongated visual acuity only by the design of the IOL. So it will be elongated. So if we compare the design and the technique, we can require the results. But of course, with a binocular surgery, it will be more good for the results in monocular EDOF. But in this study, we receive a good result by only monocular EDOF. And for the second question, can you repeat?
Okay. Is there any criteria of the patient who is suitable for this method?
Okay, for the first criteria is we have to ask the patient what are they need for what they need to get achieve after the surgery, of course, and we have to know which one is the dominant eye and non-dominant eye. Of course, in mini monovision, we have to know if we need to know that we have to get neuroadaptation after the surgery, and you have to about it because it will make uncomfortable if take times.
Okay, I think we still have more questions. However, unfortunately, the time is up. So thank you so much, Dr. Dio. And let's move on to the third presenter. That would be Dr. Laode Hamzah from INANOS free paper 03. Time is yours.
Good day, everyone. Thank you for attending my presentation. At this time, I will present our study in Makassar, the total of effect of dark chocolate and milk chocolate consumption on superficial cortical thickness in healthy young subject, a randomized double-blind crossover study. Chocolate consumption was known to affect blood flow, lowering systolic and diastolic blood pressure, and to date, there is little information about this effect to human eye. Cortical thickness has a diurnal variation. It is thickest in the night and has a negative correlation with systolic blood pressure. We aim to compare the effect of consuming dark chocolate and milk chocolate on subfoveal cortical thickness and blood pressure in healthy young subject. A randomized double-blind crossover study was used. We randomly assigned 40 eligible subjects into two groups. First group consumed dark chocolate and then milk chocolate, and other group consumed milk chocolate and then dark chocolate. Blood pressure and subfoveal thickness was measured at baseline, 30 minutes and 2 hours after consumption for each group. And for the result, data from two groups were collected. The first group contained 40 eyes and from 20 subjects, and also in group B with 40 eye from 20 subjects. And the result, there was an increase on subfoveal cortical thickness at 30 minutes and 2 hours after consumption compared to baseline, which is more in subject that consume dark chocolate compared to milk chocolate. You can see at figure 1, there is increase in subfoveal cortical thickness and more in subject in consume dark chocolate compared to milk chocolate. And for the blood pressure, we found there is no changes in blood pressure, and there was no correlation between blood pressure and subfoveal cortical thickness changes. Although there is some amount of decrease in blood systolic and diastolic blood pressure, but the amount is not significant statistically. On figure 7, we can see that there is changes on subfoveal cortical thickness in 30 minutes and 2 hours after consumption, and there is a little changes in subfoveal cortical thickness in subject that consume milk chocolate. And several studies reveal that there is diurnal variation of cortical thickness, which is thickest at the night and thinnest in the afternoon. Our study found that there is increase in subfoveal cortical thickness, and our study was conducted at 9 to 12 a.m. So these changes are more likely comes from chocolate consumption rather than diurnal variation. Changes in cortical thickness can be related to several conditions, thicker correlate on PCV and CSC, also in PK syndrome, and thin correlate on diabetic person. People taking sildenafil citrate also have an increased cortical thickness. So further research is needed whether the increase of cortical thickness have beneficial or detrimental effect. Flavonoids are known to increase peripheral blood flow. Our study found that one study found that the increased coffee latency at 30 minutes after consumption dark chocolate and concluded it was due to increased blood flow to the retina. Increase in cortical thickness found in this study could be related to increase in its blood flow. Aging is one of the factors that affect the thickness of the correlate, where older person have thinner correlate. The result of our study can be at least initial study for future research. Whether those who regularly consume dark chocolate will have a slower correlate thinning rather than those who do not consume dark chocolate. Measurement of cortical thickness for the subfoveal area should include consumption of dark chocolate in its consideration, because the result of this study found that consumption of food with high chocolate content can cause changes in cortical thickness for up to 2 hours after consumption. Whether there is relationship between changes in cortical thickness found in the study and blood flow still requires further research. And also in our study, we found that there is no changes in blood pressure. Our study limitation is that there is manually measuring chordal thickness, and the shape, color, and taste of each chocolate are different, so the subjects can could guess the type of the chocolate used in the study. For the conclusion, the study found that there was a significant increase in supraocular thickness, especially in the chocolate consumption, and there were no changes in blood pressure and no correlation found between blood pressure and supraocular thickness changes. Maybe that's all. Thank you. Assalamualaikum warahmatullahi wabarakatuh.
Thank you so much, Dr. Laudi, for your presentation. It's interesting because I really like dark chocolate. However, maybe I'm having a second thought. So Dr. Chut Samira, do you have any questions for our presenter?
Okay, thank you, Dr. Ratupuri. I have two questions. The first question was, why did you choose the method for this study is the crossover randomized? Why not the traditional randomized with control and treatment study that does not cross over for the treatment? And for the second question is, what can you take the conclusion from your study to make your practice do better? Maybe you can give some education for your patients not to take too much chocolate regarding their intraocular pressure or whatsoever. What can you tell patients regarding the conclusion of your study? Thank you.
Okay, thank you for your question. I choose the crossover study because I want to compare between two chocolates, which one is have a higher amount of polyphenol in dark chocolate. As we know that dark chocolate contain more cocoa than milk chocolate. So if I choose to use to compare between chocolate product that have a higher amount of cocoa compared to lower amount of cocoa, I can see that how much the product can affect the corroded thickness. If I compare it because the active molecule contained in this product is polyphenol. So if I compare between control and subject that consume the chocolate, I cannot make sure that if there is if the polyphenol can affect the corroid. And for the second question, maybe if I found a patient with high blood pressure, I will suggest them to eat more dark chocolate. And if the patient have eye condition that have thicker corneal thickness, like patient with CC or with Apicus syndrome, maybe I will suggest them to not take chocolate.
Poor patient. I think in this study you have quite a lot of bias to clear out. Yes. So we still have plenty of questions, however, so thank you so much for your presentation. Time is up.
Thank you.
Thank you so much, Dr. Laude. I think this time we'll clear the lines for the next presenter. That is Dr. Harsha Lutfi Ansori, INAPOS FPGR 27. Time is yours.
Assalamualaikum warahmatullahi wabarakatuh. My name is Harshal Ansari. Today I would like to present about myopia progression in children during the pandemic with spherical equivalent measurements before and during COVID-19. The risk factors for myopia is genetic factors and the environments like work at close range and less outdoor time. Myopia progression has increased during the COVID-19 pandemic due to restriction on outdoor activities. The main causes like increased screen time and reduce the outdoor activities. In COVID-19 pandemic, the increased children's screen time for online learning, social interaction, and entertainment. Like the study, the increased screen time from 2.5 hours to 7 hours per day. And there's another study that there was a link between daily screen time and myopia progression. And this is the retrospective cohort study with comparison of the spherical equivalence examination between the first and the second visit given during the pandemic. And the inclusion criteria is patient with age 8 until 17 years old were diagnosed with myopia and had hospital medical record with at least a visit from September 2019 to February 2022. And the exclusion criteria is incomplete medical records. And then the refractive examination of the child eyes involved a standardized procedure preceded by the use of cycloplegic eye drops. Data such as family history, screen time duration, after activities were collected through in-person and telephone interviews. Progression of myopia was categorized based on the change in spherical equivalence degree between two different visits. We use a paired t-test to compare the spherical equivalence. And the result, total 165 patients with visits with the inclusion criteria in 11 people. And characterized as predominance in female with 6 people. And then the family history with 6 people with positive family history with myopia. And then the screen time mean rate is 202 minutes and the outdoor activity is 42 minutes. And then the myopia progression had more slow progression in 8 people with the fast progression in 3 people. And then had a significantly result with the mean as 1.55 dioptry with p-value 0.046. And then there were 165 visits of patients with age 8 until 17 years with diagnosed myopia. This study involved a sample of 11 patients, 6 female and 5 female. There's gender differences in myopia rates were observed in our study, like study by Liu showed a higher prevalence of female, meanwhile study by Ma showed a higher prevalence in males. And then there's genetic factors play a role in the progression of myopia. 6 out of 11 patients had a family history of myopia. Also, study by Liu found a significant association between family history and myopia incidences. And then the COVID-19 pandemic increase in gadget use and decrease in outdoor activities in children in our study. The mean screen time in this study was 202 minutes, exceeding the World Health Organization recommendation. There's 2 hours per day in screen time for children. And there is increased screen time during and decreased outdoor activities in the pandemic were associated with myopia progression. And the mean change in spherical equivalence during the pandemic in this study was minus 1.55 dioptry. Also, that study with Ma also showed myopia progression during the pandemic with a mean of spherical equivalent change of minus 0.9 dioptry, and with the before the pandemic, the mean is minus 0.3 dioptry. Also, study by Mohan state that increase of gadget use and decrease outdoor activity with children during the pandemic were associated with significant increase in the mean spherical equivalent. And then the conclusions: the COVID-19 pandemic made outdoor activities limited and increase the use of gadgets in children's learning. That also increase the risk of myopia progression. Thank you. Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh. Thank you so much, Dr. Hasha, for your presentation. I think I have one question. Why did you include patients from 8 to 17 years old and not the younger children as well?
Okay, thank you, Dr. Ratu Puri, for the question. The answer is we choose that we know that some research that emmetropization is final in the mean is from 7 years old, and then the school children's that increase the higher use from the school, we know as elementary school until senior high school is from, we know that's from rate 7, 8 until 17 years old, and the children's mainly can use the gadgets. The rate is from that age, Doctor.
Okay, it's because I think yes, please.
Yeah, so that we can conclude that the maybe the exact data for the use of gadgets in 8 until 17 years old.
Okay, because I think nowadays the use of gadgets is more in the younger age group, and also up until 18 years old, there's still an axial elongation. So I think if you want to make the studies more impactful, you have to include also the younger population. And also, how long is the 2 visits between this patient? The 2 visits? Is it 2 years?
No, in our study that we found that the rate is 4 months, but in 11 there is 4 months, 10 months, and the longest is 1 year.
Okay, I mean it's something that we have to consider. Maybe we have to talk to the patients to go for a follow-up. From 165 patient, only 11 got the inclusion criteria. Okay, I think 2 minutes is too short of a time, isn't it? Okay, thank you so much, Dr. Hasha. Now we'll move. Sorry, I'm still mute. Next presenter will be Dr. Ifada Haryani Kusuma. Okay, your video up soon.
Assalamualaikum warahmatullahi wabarakatuh. My name is Ifada Haryani Kusuma. I would like to present our research about the methods of assessing visual acuity in children in community setting in Malang. I would like to introduce about the background, objective, and benefit of this research. The background of this research is the refractive error is the most common cause of eye disorders in children. If this left untreated, it will lead to lazy eye. Also, the VA exam in children is also challenging. The objective of this research is to find out what methods should be used. And the benefit of this research is to find out the effectiveness of some exam methods and to find out children's VA. The methods of this research was observational, descriptive study based on secondary data obtained during community service into orphan in Malang. It included 57 children, and we had already obtained the informed consent from the guardians. And here are some variables. We divided the age group into 3 categories. Male and female gender both were included. We used 4 different methods, including Leah numbers, Leah symbols, ivory balls, and mounted balls. The results is the most participants were 6 to 12 years old. which was 26 children, and the most participants were male. From the exam results, we found that most of the children had normal vision, which was almost 58%. And this is the pie chart of the methods we used. The most used methods were layer numbers and layer symbols. This is the age distribution based on the methods used. The yellow bar indicates mounted ball, and the gray one is for ivory ball. The orange one is layer symbols, and the blue bars indicates layer numbers. Based on the data obtained, I would like to discuss about our findings. The examination in children is challenging, moreover in community setting. This is due to cognitive capacity and non-cooperative. Attention span of the children is also decreased, and it also there is interaction with the examiner also challenging. The estimated age span assessed with the available methods, we found that layer number is used for 5 to 12 years old. Layer symbols can be used for 3 to 5 years old, ivory ball for 1.5 to 3 years old, and mounted ball is used for half year to 3 years old. Here are some limitations. There was crowded and noisy environment. Also, children's focus was distracted. We also have low number of samples and the different number of age groups, and no specific inclusion and exclusion criteria, and we have no socio-demographic variables. The strength of our methods were adaptive and suitable for children's developmental stage. The tools were easy to obtain and the preparation was simpler. The conclusion was layer numbers, layer symbols, ivory balls, mounted balls could be used to measure children's VA, and the children were cooperative enough and understand instruction. And we suggest that we use separate room and we suggest to use monochrome clothes and increase the samples for further research. There is no conflict of interest and no financial disclosure. As final words, I want to thank you for your kindness to watch our presentation. Wassalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh. Thank you, Dr. Ifada. Dr. Chusamira, please. Do you have any comments?
Actually, I have so many questions for your study. So you already stated that your study also have a lot of weakness, a lot of limitation. What the most important thing is the inclusion and exclusion criteria. What do you think? Maybe if you can rewind your study, what is the inclusion and exclusion criteria? The proper criteria for your study that make the results more powerful, or maybe what can you do better for this study? Thank you.
Thank you for the question, Dr. Samira. I think we should include some inclusion criteria, such as the number of children based on age group, and we have to exclude some disease. I mean, we have to examine children that have no limitations, such as on my study, we have one children with nystagmus and hydrocephalus and one children with hydrocephalus. So I think we have to exclude any disease before. Thank you.
Okay, about the methods, maybe you can give more difference between one groups and based on the age, or maybe based on the treatment you give for the sample. What can you do better for this study?
I think we can divide the group based on the age group, such as for the children with 5 years old and older, we can use layer numbers. But in this community settings, some of 5 years old cannot read numbers, so we can switch to layer symbol instead. And for 5 years old and younger, we can use the less symbol, and we can switch to ivory ball for the children with the age group between half-year-old and 3 years old.
Okay, so yeah, I
Thank
guess
you.
that's all.
Okay, thank you, Dr. Cut Samira. Thank you, Dr. Ifaja. And last but not least, I will introduce the last speaker of this session is Dr. Maria Angelia, INA VRS FPGR 23.
Good morning, doctors. I'm here today representing my group to elaborate further about our paper. As we know, AMD is a chronic and degenerative disease of the central retina. It is the primary cause of blindness in developed countries, particularly among individuals aged 60 years and above. And this AMD incidence is expected to rise by 288 million in 2040. And this AMD event is decreasing quality of life, which could lead to increasing burden of healthcare resources. The anti-VEGF, the current pharmacological approach, is limited to slowing down the progression of neovascular AMD. There is no effective treatment for the rest step of AMD. Due to this reason, there are plenty of studies that identifying the modifiable risk factors to prevent or slow down the AMD, namely the AREDS or AREDS2 study. The Mediterranean diet, or MD, has been associated with decreasing incidence rates of cardiovascular disease, cognitive deterioration, dementia, and age-related ocular disease, including AMD. Therefore, we aim to investigate the potential correlation between adherence to Mediterranean diet as a modifiable AMD risk factor. This is the methods that we use in our study. This is the characteristic of the included study. We found numerous factors that significantly contribute as the protective and the risky factor to the AMD. We also found that the adherence to MD appears to protect against the development of AMD. Medium-high adherence to AMD significantly protective to the progression of advanced AMD. Then we do a sub-analysis between the medium and high adherence group. Both of them are protective to the progression of advanced AMD. However, the risk reduction is more remarkable in the higher adherence compared to the medium or combination group. Nevertheless, there were inconsistency in the finding regarding the type of advanced AMD that were impacted. We didn't find any significant relationship between the early stage of AMD and the MD adherence. However, we found that higher adherence to Mediterranean diet tends to lower the risk of two-step drusen progression, reduce the odds of large drusen, and the incidence of ARM2. The Mediterranean diet is a dietary pattern that rich in antioxidant, mineral, vitamins, and anti-inflammatory properties. And it's been linked to be protective against the cardiovascular, inflammatory, metabolic, neurodegenerative ocular disease. 50% high fat content of MD is MUVA. The most consumed MUVA are extra virgin olive oil or EVO. It consists of polyphenol that drive anti-inflammatory and antioxidant. Another MD component, fish, contain omega-3 PUVA that have consistently linked to the decreased advanced AMD as we found in our study. The progression of GA was higher than neovascular AMD. This is maybe because the GA is hypothesized as NVAMD precursor. So it seems that GA is the initial step of the progression to a late AMD. Then there are numerous risk factors that contributing to the lead that lead to AMD aside from diet. And most of this risk factor has been adjusted to minimize the bias. However, there is no study adjusted for the late stage AMD in the fellow eye. This is the limitation and the strength of our study. As the culture, geography, economy, and availability of the local food influence the dietary pattern in a population, we suggest further research about the correlation between a modified MD aligned with Indonesian food and AMD. We recommend applying the diet for prevention and slowing down the progression for AMD in older population. As there's no effective treatment for AMD, MD is a promising intervention, so it should be developed more widely. Thank you for your attention.
Thank you, Dr. Maria. Yeah, AMD is too multifactorial to point out which one is responsible for the progression, let alone progression to neovascular AMD. My question would be, in real world, in your practice, what would you suggest to your patients for your AMD patient? Is it to maybe change your coconut oil to olive oil or anything? Which one would you think it will be applicable for your Indonesian patients?
Okay, thank you, Dr. Ratu, for the question. Probably, if my patient is AMD patient, I would like to suggest he or she to change her or his whole dietary pattern instead of adding just one single nutrient, such as please eat more vegetable or eat more fruits, but I suggest to eat more balanced diet. So he or she can still eat any food they want, but please emphasize to eat more vegetable, fruits, grains. Probably in Indonesia known for tempe, pecel, that plenty of vegetable, or rujak, plenty of fruits, something like that.
Okay.
Maybe that's
I think you also have to consider whether patients have any comorbidities that they cannot eat fruits, for example, or maybe they cannot consume seeds, right? If they have gout and all. So yeah, I think that's something to consider in these studies. Maybe Dr. Putri, do you want to add some other things?
Yeah, I guess you must consider other factor than bias that also told Dr. Ratupuri, like comorbidity in the eyes, like other systemic disease, it can influence your results.
Yeah, and I think you need to also coordination with other specialization. Yeah.
Older
busy
patients
clinic,
have
for
a lot of
example.
issues.
Yeah.
We're talking about older patient, geriatric patients. They have many
True.
diseases.
Yeah, they have other comorbidities. So unfortunately, our time is up. So thank you so much for our presenter today. Is there anything that the community wants to explain to the presenters, or we just end our session today from the committee?
Thank you, Dr. Puri. There is no additional information for the participant.
Okay. All right, then. Thank you so much for your cooperation for this session. So I'll close this session. Thank you so much, Dr. Chut Samira, for your co-moderating. So I'll see you soon in Jogja. Thank you so much.
Thank you,
Assalamualaikum
everyone.
warahmatullahi wabarakatuh.
See you soon, dokter.
Bye-bye.
Untuk dokter Puri dan dokter Tirtamira, mohon izin dok, sedikit informasi untuk dokter. Untuk peserta lainnya dipersilakan apabila mau lift terlebih dahulu dokter. Atau mau foto dulu dok, kami persilakan dok.
Boleh.
Ya, ya untuk peserta yang masih di sini nanti bisa kita foto bersama dulu aja ya.